Elimination Part 2. This is Martha Olson, Introduction to Nursing Concepts. Potter and Perry, chapters 45 and 46. As we continue on looking at the nursing care with elimination, some of the tests that we do, the urinalysis or the UA is the most commonly performed test that is done. We see it done in all settings, from the clinic all the way through to the patient that's admitted. We do urinalysis looking for renal disease, urinary tract infections. On page 1053, it talks about how the simple urinalysis really doesn't require a sterile specimen. How we do want to obtain that is by having the patient void just a little bit to flush the bacteria from the lower part of that urinary tract, and then collect the specimen in the sterile cup. We usually see them as the orange topped little cups. We label it and send it to lab for the urinalysis to be completed. Make sure on that UA that it is dated and timed so that they know that it hasn't sat out or been contaminated, not being refrigerated. You will want to make sure that you note the color, any odor, clarity, and then any sediment in that. If you look on table 45-2, it should give you some clues as to the urinalysis and the screening tool. A UA is commonly done before surgery to make sure that they do not have a UA. Every time I go into the clinic, my doctor runs a UA just simply because he said many women have urinary tract infections and they do not know it, and so he detects a lot of them by just running a routine UA. Any of your kindergarten physicals, any physical usually involves a UA. Page 1053 is where you're going to see that. The other part of a UA, if they order a culture and sensitivity or CNS with that, it takes about 24 to 48 hours to grow the bacteria. Many of them will be started on a broad spectrum antibiotic before that culture comes back. And the sensitivity part of that, remember, is telling you which antibiotic is going to be most effective. As we assess urine, it becomes part of our nursing assessment every time we assist a patient to the bathroom or empty their catheter. We look at urine output as a key indicator of function of the kidney. In the intensive care unit, I watch the output hourly on any patient that's admitted with problems with elimination. If after an hour I don't have 30 cc's of urine in that catheter, I need to reassess that patient and call the surgeon and find out what they want to do. Many times it's somebody that had a large blood volume loss from surgery and they are not having enough blood pressure to spin the nephrons to produce the urine output, and then we do a fluid challenge for them. Or it helps us to know that there is other problems with the fluid and electrolyte balance that we need to be keeping track of. Remember, the 30 cc's an hour is kind of a golden rule, but it only pertains to adults. So when you start looking at the pediatric population, it would be based on their weight, cc's per kilograms. Our nursing history is looking at their pattern of urination. You know, it seems like some people urinate very often, and then there's other people that only go, 2 or 3 times a day. Things that affect urination, some of the medications like diuretics that make you void more often, if they're mobile and able to get up to the bathroom. Otherwise, there are some people with mobility issues that hold it just simply because maybe it's very painful because their leg is in a cast or they have a broken pelvis and they hate using the bedpan. Environmental barriers such as there's no bathroom available and so you're in the car waiting until you get to the next town. Or sensory restrictions where maybe you have some neurological damage and you don't feel the urge to void at that time with maybe like a spinal cord injury. A sterile specimen is obtained only by catheterization. When we need a sterile specimen, we usually put a catheter in the sterile technique, obtain our specimen, and then remove it. We can also get it from an indwelling catheter, and we need to look at that skill because when we take it out of the indwelling catheter, we would want to make sure we take it out of the port because in the bag it will be contaminated from the previous urine that has been in there. Working in the clinic when they do the sports physicals every August, you have about 25% of the girls that come in for their sports physical that will be having their period. and their menses will alter that UA and show that it has blood in it. So when we work in the clinic doing sports physicals or physicals, ask these young women, are you having your period? And if so, if it's just a routine physical, they usually tell them to come back and give a UA when they're done with their period. Otherwise, if you need the UA right away, we would do what we call a mini cath, and I will have one of those to show you in class what that looks like and how you would obtain that. When we get that specimen from an indwelling catheter, remember we have a sampling port. You will simply put a needleless device on there and pull the urine out from that. You may have to clamp off your tubing for a bit to get some urine to pool in that tubing to be able to get that urine, but it's a very effective way to be able to get a urine sample from somebody that has a catheter. When you insert the catheter, you can take it out of the bag because it is sterile at that time, but if you haven't, like I said, just inserted that catheter, if it's been there a while, we need to take it out of the port. Our normal values are listed on page 1054. We always want to look for the color because that tells us a lot about their hydration status. If it's a very dark amber urine, they're pretty dehydrated because their body is holding on to fluid, and they send the waste product out then in a very small volume of urine output. When we look for the blood, that can tell us about kidney damage, or like I said earlier, maybe the ureter got nicked during surgery, or it could be contaminated from a female. When we look at ketones, that's telling us about diabetes and if they are breaking down protein and the waste product is the ketone products. Again, our glucose, we should be negative. If you have somebody that's an undiagnosed diabetic, they may be spilling glucose into their urine. So all of these things from page 1054, good to know about. Protein normally is not present unless the person has renal disease, and I think of protein as a very large particle. Just like when you make macaroni and you use the wrong size strainer and the holes of your strainer are too large, your macaroni falls out into your sink when you're draining it. That's what happens when you have kidney failure, because that large protein is then allowed to go through that large strainer because the filtering ability of that kidney has been lost. Our urine changes color then with some of the foods that we eat. It's normally yellow or a light straw to amber color, and things that can change that are some of the medications that we will be talking about, such as pyridium, which is a medication given for a urinary tract infection that does not help the infection, but pyridium takes away that urge that you have to void all the time. So it's kind of an antiseptic or a pain pill for the bladder in a sense. Elavil is a mood stabilizing medication you'll learn in mental health, and that can turn the urine kind of a blue-green. The only thing important is to know that they've had that med, so when they have orange urine, you don't panic, but to also tell the patient, because it does become kind of disturbing when their urine is a much different color. You know that different foods that you eat in the summer can cause the food or the urine to change how it smells. That asparagus seems to be the one in the spring that when you eat a large amount of asparagus, you can tell because your urine has just kind of a different odor to it. So all of these things become important as we look at documentation and noticing changes in our patient status. What we should not have in urine, again, is our glucose, and any protein should not be found in there. I think I skipped one. Our specific gravity of urine, less than 1.01, is from a patient that's overhydrated. They've drank a lot of fluid, because our normal specific gravity tells us about the ability of the kidneys to concentrate urine. On page 1054, we think about the person that's dehydrated or decreased fluid intake would have a specific gravity of 1.03 or higher, and it again just tells us the amount of proportion of dissolved solid to that water that we have. Other things that should not be found in urine are ketones, because they are a sign of starvation during children, during your febrile illness, or with a high fever would have that. And with bacteria in the urine, they're going to determine it's either gram-positive or gram-negative so that we can get the right antibiotic started for that person. When we collect our specimens and get them to the lab, make sure that they are always labeled appropriately with the time and the date that it was collected. And then after it's taken, you put it in some kind of secure container. Now in Estherville, we put them in Ziploc baggies and take them to the lab. In Emmitsburg, they've got a little black box that they send it to the lab in, so that when you're walking down the hall, you don't see the nurse carrying that urine to the lab at that time. On page 1053, it talks about timed urine specimens. And we will be talking about that a little more, but that is where you discard the very first voided specimen, and then for the next 24 hours you keep every bit of urine that is voided, and you keep it on ice in the bathroom, and then after the 24 hours that last voided specimen is sent down. And what they're really looking for in that specimen is hormones, the amount of hormone in a 24-hour period that that person has. Things that can interfere with the testing if you don't have enough. And if you're not sure, send down what you have and just ask the lab, is there enough? Because sometimes patients come in and they are so dehydrated that you may only get 20 mils of urine out from them because that's all they have. If it's contaminated, we need to get another one. And then if, again, it sits out on the desk for a long period of time, it would be considered contaminated, and we would not want to run that because it would give a false positive result. Our tests then that go with the bowel, we're going to be talking about a UGI, or upper gastrointestinal or barium swallow. On page 1101, we look at what the nurse is responsible for. Again, you see the pre and post. These would be typical questions on NCLEX. This is the test where we go in with a scope and look at the esophagus, stomach, and duodenum. And because it is considered a more serious or invasive type of test, we would want a consent. They have to be NPO so they don't aspirate. And then the prep would be to numb that, and probably a clear liquid diet before. Afterwards, you see where it talks about laxatives after the exam. In the new 8th edition of Potter and Perry, it simply states that you would increase fluids. In this area, they still order laxatives after an upper GI because barium is very constipating, and many of these people will not drink enough water, and they will get a very hard ileus, or a very hard white chalky-like barium stool that they are not able to expel. And so we want to avoid that at all costs with them. Other diagnostic tests then, on page 1055 is where it talks about the bladder or urine elimination tests, and then our bowel tests are on page 1101. Your IVP for the bladder, or KUB, which stands for kidneys, ureter, and bladder, they send a dye down through those three structures so they can look via x-rays at what is going on. Is there a stricture to that ureter that we need to know about? And you can see it then when they are taking those pictures with that. As you look at this order of bowel, it talks about the scopes, the x-rays, CT, MRI, and ultrasound. Get in the habit of thinking, which one as a nurse would I do first? Which one would I have the patient do first? On this particular one, we would probably have the ultrasound and the x-ray done first because there's no prep and there's no dye involved. And then your scope would obviously come last because you will have to clean that whole bowel out in order for the doctor to go up through the rectum and scope and be able to look at that colon on the inside. We will be practicing some of these in class, but back to the bladder on page 1055, that KUB, take note that that is done with some iodine-based dye, and so you would want to make sure that you assess for an iodine allergy before they would have that test. They need a bowel cleansing, they need clear liquids with checking the allergies, and then encourage, again, the patient to drink a lot of fluids afterwards to flush that out. These are our nursing implications. That's where your test questions will come from, because you can know what a test does, but they want to know on boards, do you as a nurse know what we do before and what we watch for after a patient returns from a test that they've had? this ends our Unit 2 elimination slide. I'll be on to Unit 3 next. Thank you.